All right, endocrinology, it's fall 2020. It is Monday. It is week 2. Off we go. So let's look a little more closely. We're talking about the Tasmanian devil here. The angiotensin II has widespread effects on the body. Let's check some of those out. Remember your anatomy now. Here's a cross-section through the adrenal gland. I remember it by GFR, the glomerular filtration rate. Remember that one? You can use that for the layers of the adrenal cortex. So G for zona glomerulosa, F for zona fasciculata, and R for zona reticularis. What are the cells for those layers? Well, the same thing. Glomerulosa cells, fasciculata cells, and reticular cells. So some kind of easy stuff, or made simpler. That doesn't work for the medulla, but the chromophene cells in there. We'll look at those, I think, today as well. Angiotensin II versus aldosterone. Angiotensin II has the ability to bind to glomerulosa cells, of course, in the adrenal gland. Specifically, it binds to its angiotensin II type 1 receptor. I'm just going to call that AT1 receptors. That binding causes the release of the hormone aldosterone. Angiotensin II is actually the strongest stimulator for aldosterone release. Increased levels of potassium ion in the serum are the number one. Fun facts, cortisol can actually bind. Did you know cortisol can bind to AT type 1, angiotensin II type 1 receptors? Yes, it can, and it makes things a little confusing. We'll get to that more in a bit. What does aldosterone do in general? Well, you know that, right? It causes the conservation or the reabsorption of salt in water from the glomerular filtrate. And if you get salt and water into the blood, it's going to increase the volume and it's going to increase the pressure. And we said before, it's a slow mechanism. It doesn't happen super fast. If you've got a bad bleed, that's not going to help you much. It takes about an hour or so to kick in. What about, let's look at number 2 effect of angiotensin, smooth muscle. Angiotensin II can also bind to receptors on the smooth muscle cells of arterioles and venules. And yeah, flat out bind to it, and it causes the constriction of the blood vessels. It causes venous or vasoconstriction. Right? That makes sense because in our scenario we've been talking about a bleed. So we want to boost the blood pressure. Why not cause a vasoconstriction of the blood vessels, which would increase blood pressure? This is a little faster than aldosterone mechanism, but not as fast as the sympathetic tiger. This mainly helps increase blood pressure that was, or it also helps to maintain blood pressure that was increased via the sympathetic system and the nerve of Herring and glossopharyngeal route, which we'll take a peek at again in case you don't remember that. More specifically, we can get a little deeper into that. Angiotensin II actually uses angiotensin type 2 binding receptors. We'll just call them AT2 receptors, which are located on the vascular smooth muscle of arterioles, we'll say. And this binding stimulates that second messenger system, the diacylglycerol inositol triphosphate, nicely known as the IP3 system. I'm sure you've studied that in biochemistry. So that system, what does it do? That causes the endoplasmic reticulum in the smooth muscle cell to dump calcium ion out into the cytosol. And that, of course, stimulates the contraction of actin and myosin and causes a tension of the smooth muscle, which decreases the lumen size, which boosts up blood pressure. What else does angiotensin do? How about its effect on the medulla of the adrenal gland? Yep, it stimulates with it binds to chromophene cells, which live in the adrenal medulla, which in turn stimulates the release of epinephrine from the medulla, as well as some of the other catecholamines. Remember we said the catecholamines were epinephrine, norepinephrine, and norepinephrine, but the major one is epinephrine, aka adrenaline. So what's the deal with that? There's just showing angiotensin II doesn't show the cells, but it's binding to chromophene cells here and causing the release mainly of epinephrine. About 20% of that release is norepinephrine and probably 1% is dopamine. So what does epinephrine do? Epinephrine really has an effect for this purpose on the skin, we'll talk about, because we're trying to conserve blood. So if you're bleeding, if you have your spleens ruptured and bleeding, why do we need to supply our skin with blood? And we don't. So epinephrine will shut down the skin. Specifically, it shuts down that hypodermal venous plexus. That is supplied by an AV bypass. We'll take a look at a picture of that in a second. And we can basically shut off almost all the blood supply to the skin. That's why people in shock, they're cold and clammy and slimy, because it stimulates, sympathetics stimulate the saliva glands, the sweat glands, so they get cold, clammy, and sweaty when sympathetics are raging. But yeah, why need the skin? We'll save that blood for the brain and the kidneys and the heart. And that's exactly what it does. Let's see where it affects. So this is an AV anastomosis here, these pipes. So here's blood flow going like this. And normally on a normal day, the blood would dump into this venous plexus here, and it would circulate and feed all the cells of the dermis. It would circulate up and feed the epidermal cells, the ones that are still alive. But if you're bleeding, we can shut these things right off, and that's exactly what epinephrine does. It shuts down those AV anastomoses. Epinephrine versus heart and blood. Epinephrine also soaks into the SA node and stimulates it to speed up the heart rate, because we don't have as much blood anymore, so we need to get the heart cranking to speed up the circulation. It also soaks into the AV node. Normally we have a slowdown, right, when the signal goes from atria into the ventricles. It slows down that signal, but we don't, if you're fighting for your life and you don't have a lot of blood, we don't worry about slowing down that signal. So it basically shuts off, or almost shuts off completely, that decremental deconduction. So the AV node lets the signal go pretty quickly through there, which also works to speed up the heart rate. The epinephrine also soaks into heart muscle and causes increased contractility of the myocardial muscle of the heart, makes it contract more powerfully with each beat. Little redundancy here for number 4. Like epinephrine, angiotensin II can also bind to cardiac myocytes directly, and it does so. It causes the release of calcium into the cytosol, which causes the heart muscle to beat more powerfully. Remember, sympathetics are also directly plugged into cardiac myocytes, which also does the same thing, causes them to release calcium ion, which increases cardiac contractility. Heart beats stronger and forces more blood. So a little redundancy between the sympathetic tiger and angiotensin II. What else does angiotensin II? It prolongs sympathetic outflow to the vasomotor center. Remember the vasomotor center, I say it's like a tiger cage gate. The tiger's the sympathetic monster, and it's locked in the vasomotor center by this bar. That bar is cranial nerve 9 and the nerve of Herring, and the carotid sinus is what keeps it closed. But angiotensin, it can, once the tiger is let out of the cage, angiotensin II can keep the cage door open and keep the carotid sinus less sensitive to the hypertension that is being created out there. Because normally the carotid sinus would sense the hypertension, and it would shut the cage door and keep the sympathetics in. You don't want that if someone's bleeding, so it decreases the carotid sinus sensitivity. And this is a pretty quick mechanism here, by the way. Little rabbit hole. Remember the carotid sinus? I think you guys are good with this, but the carotid sinus is right at the takeoff of the internal carotid artery, and this nerve is called the nerve of Herring right here, or the sinus nerve of Herring. That dumps right into the glossopharyngeal nerve. Glossopharyngeal nerve, you can think of that as this stick pressing up against the tiger cage gate. We don't want sympathetics coming out, because that'll cause hypertension. Once the blood pressure is normal, this stick is pretty strong, and it keeps the tiger in its cage. If you get a drop in blood pressure, you also get a decrease of action potentials flowing down this nerve of Herring and cranial nerve 9, and therefore the stick starts to open and the tiger cage gets loose. Remember that from physiology? Once the tiger cage, here's the scenario again, decreased blood pressure, so you have a decreased firing in the nerve of hearing and the cranial nerve 9, glossopharyngeal nerve. That opens the tiger cage gate, so here's the tiger on the loose. And remember the main functions of the tiger. It goes into the heart and it goes into the SA node and causes it to beat faster. It goes into the AV node and slows down decremental conduction, turns that off. It goes into the myocardial sites of the heart and causes them to beat more powerfully. It goes to the arterioles and venules and causes them to contract. And you have increased vascular tone, you could say. The smooth muscle is contracted, which boosts blood pressure. Right? The goal is to fix this problem right here. Then it also goes into the kidney and it causes vasoconstriction of the afferent and efferent arterioles, which decreases blood flow to the glomerulus, and that freaks out the macula densa and it freaks out the juxtaglomerular cells to release renin. And renin goes right back and starts the whole cycle again. But all of these things end up increasing blood pressure. So that's a nice little slide there. All right, what else does angiotensin II? There's a thirst and salt story as well. Angiotensin II has receptors in the hypothalamus that, when stimulated, make you thirsty and make you crave salt. What would that have to do with blood pressure? Well, if you drink more water, that's going to boost the volume, the blood volume. And if you eat more salt, that's going to make you more thirsty, so you drink more water, and those are going to boost up the blood volume, which increases pressure. It's not a very powerful mechanism, however, but every little bit helps when you're bleeding out. What about the proximal convoluted tubules? Oh yeah, angiotensin II has receptors on the proximal convoluted tubules. Remember, those are where the potato pickers are, or the sodium pickers. We use the analogy of a potato picker picking potatoes off a conveyor belt. It can stimulate those pickers to pick faster. So if they pick faster, and not potatoes, but if they pick more sodium out of the filtrate, then there's more water follows, and then you have more sodium retention and more water retention, and that's going to boost the blood volume even more. Okay, the decreased sodium concentration of the filtrate, because we picked out sodium, that's going to freak out the macula densa, and that's going to stimulate the release of more renin. What else does it do? Yep, it does even more. Angiotensin binds with a smooth muscle of afferent arteriole. Oh, I just said this. Afferent arterioles around the glomerulus. Binding causes a vasoconstriction. Everything I just said. Did I go backwards? Or well, how did that get out of place? I don't know what happened. And what else? Angiotensin II can actually go up to magnocellular neurons in the hypothalamus and bind to them, which stimulates the release of antidiuretic hormone. This is lots of stars on this slide. This is a very important mechanism. So it's slow, but nevertheless, aldosterone or antidiuretic hormone, ADH, or arginine vasopressin, all those AKAs, it of course has an effect on the kidney to reabsorb free water. And free water in the blood boosts blood volume, which is going to boost blood pressure. How about some inhibitors of angiotensin II? How about some inhibitors of renin? In other words, inhibitors of the R2A cycle. Hypertension, of course, that'll stimulate the release of the natriuretic hormones like ANP, BNP, and CNP, and those all work against angiotensin II and turn that off. Hypernatremia, if you have a really high salt diet, or if you have kidney failure and your kidneys aren't able to clear sodium from your bloodstream, because if you eat too much, if you have McDonald's, have salty fries, what clears that salt out of your bloodstream? Usually your proximal convoluted tubule just kicks it out more than usual. But if you overload and the potato pickers can't pick enough, then that's a cause of hypernatremia. And so is, of course, kidneys not being able to reabsorb enough sodium out of there. So that could cause hypertension in people. And we'll look at the salt-sensitive people. Some people's potato pickers aren't the greatest, and they have to be careful with salt in their diet because it can build up and cause hypertension just because the potato pickers of the proximal convoluted tubule aren't working that good. Chronic activation. That's no good. We talked about that last time. Having angiotensin II around is not good. Having aldosterone is about the same thing, but it's not as bad as angiotensin II. So patients with chronic hypotension, like people with heart failure or aortic stenosis or any beaver dam in the heart where you get a decreased ejection fraction, you're going to have hypotension. Well, that's okay because you're going to turn on the R2A system, but it's going to be all the time, and it tends to overdo it. It's not going to give you a perfect 180 over 120 blood pressure. It's going to make it high, like 150 over 95, and that's not good. Research is very strong in this. If you have too much, well, if you have the R2A system on, you're going to have too much angiotensin II around all the time, and you're going to have too much aldosterone around all the time, and that can wreck the heart and the blood vessels. Okay, how does that work? So aldosterone and angiotensin II can turn on certain genes in myocardial tissue and myocardial cells, and those genes overproduce things like certain growth factors and turn on cytokines which cause an inflammation of the heart. But it's the growth factors that are really troubling. Growth factors and can stimulate fibroblasts unnecessarily to lay down collagen. Fibroblasts are great if you've damaged your heart and you need to repair something. Otherwise, they just sit there. But if you have too much angiotensin II, too much aldosterone, those guys are stimulated and they start laying down scar tissue in your heart between the myocardial cells, and your heart starts to get really big and really stiff, and it gets wrecked. And that is not good. It causes cardiac hypertrophy, and it decreases the heart's ability to pump blood. Then you get into this vicious cycle here, where the heart now has lost. Maybe you had a weak heart to begin with, and you had maybe a 10% decreased ejection fraction, enough to turn on the R2A system. But now you go through that same pathway I just talked about, and the heart gets damaged. And because the heart is damaged, now it pumps 20% less blood. It's terrible, 20%, isn't it? But now that turns on more angiotensin II, and that damages more of the heart, so now you got 30% loss of ejection fraction, and that causes more angiotensin II to be, it turns on, it stimulates the R2A system even stronger. See how you can get that vicious cycle going by that type of setup. How do you block angiotensin II? People who have angiotensin II induced hypertension, well, they have chronic levels of angiotensin II. We just said that's really bad. So how do you prevent that? The only way to really prevent that is two types of medication. And if you monkey around with doing fringe treatments and you can't get that blood pressure down, your heart is going to be wrecked. I'm a chiropractor, but I'm a scientific, logical chiropractor who goes by the medical literature database. And there's no question that ACE inhibitors are very effective at lowering blood pressure in people with this scenario. There's another option as well, angiotensin II receptor blocker, or ARBs. We won't go, I took a bunch of slides out of here because I was getting too crazy into these things. But I think if you just know ACE inhibitors, angiotensin II blockers are trouble. I took a COVID section out of here too. This is how fast things are changing. They used to think that by taking these ACE inhibitors, it would spring more ACE2 receptors up in the pulmonary tissue and make people more susceptible. But turns out that didn't happen. In fact, there might be even some protective mechanism by taking ACE2 inhibitors. So if you're on these things, you don't have to come off them because of worries of COVID-19. They're still safe to take. What about the effect on the adrenal gland? Let's go a little deeper. Angiotensin versus aldosterone. So the adrenal gland, and we already know angiotensin II targets the outer layer of the adrenal gland, specifically angiotensin type 2 receptors. They live in the zona glomerulosa. Specifically, it binds to glomerulosa cells. We already know all this. We said this before. So it stimulates the release of aldosterone. We know that. Are there other aldosterone stimulators? Can anything else stimulate glomerulosa cells? Actually, ACTH, adrenocorticotropic hormone, has an ability to bind to glomerulosa cells a little bit. So they can stimulate a little bit of aldosterone release, but it's very weak and you can't live with that alone. But for full power secretion of aldosterone, you do need a functioning zona fasciculata, and it's because ACH or AC, you need a functioning pituitary because you do need that ACTH. But the other thing, the strongest effect is of all, which really stimulates the release of aldosterone, greater than the angiotensin II, is hyperkalemia. The body does not like high levels of potassium. Those can destroy the heart and cause fatal arrhythmias, and the body's very sensitive about that stuff. Here's a little review slide. I'm not going to go through all this, but just to show you, angiotensin II can bind to the zona glomerulosa, cause the release of aldosterone. That should be increased potassium. Okay, slide 30, I need to fix that. I think I say that, I always forget. It's hard to remember 30, I can't remember. 30 something, was that a TV show? Or was that 40 something? I'll try to remember. See, I'm trying to hook that in my brain because I don't have any paper. But increased potassium can also stimulate that because we want potassium kicked out. So aldosterone kicks out potassium and hydrogen ion. Okay, and then ACTH can stimulate it a little bit as well. Right, let's look at aldosterone. How do you make aldosterone anyway? You should have learned this in biochem already, so should be review for you. But we use cholesterol. There are 3 key enzymes to make aldosterone here. We need desmolase that makes pregabalin. Pregabalin is converted into progesterone by an enzyme that is always present, and we don't even have to worry about it because there's not a deficiency. So you can forget that one. You can say cholesterol is easily converted into progesterone. And then progesterone is converted into deoxycorticosterone by 21-hydroxylase. If you remember one enzyme, if you remember one thing from today, well, everything's important today. But 21-hydroxylase is very important. You get a gene mutation in the 21-hydroxylase gene, and there's AKAs for these things too, but this is clinically what they call it. You lose 21-hydroxylase, you're in big trouble. You can't make cortisol, or you can't make aldosterone, or you can't make it well. Usually if you completely mutate the gene and you can't make this, you're not alive very long when you're born. But usually it's not a very good, well-functioning enzyme, so you have trouble making cortisol and aldosterone. And then aldosterone synthase is the final step. That's also called a cytochrome P11B or beta 2 enzyme. But just for me, just know them as the old clinical, where these are the ones that will show up on boards: aldosterone synthase, 21-hydroxylase, desmolase. Right? And here's the biochemistry. They should have covered this in biochemistry. Of course, angiotensin binds to a glomerulosa cell, and it stimulates IP3 pathway. IP3 pathway, we know, causes the release of calcium ion from endoplasmic reticulum. Calcium stimulates CAM kinase 2 to cause the gene expression of our friend, the star protein. There's a star mRNA that goes to the ribosome, and the star protein binds to the mitochondria and allows cholesterol to go inside the mitochondria, where it's grabbed by the P450 SSC enzyme and turned into pregabalin, which is converted into progesterone. Remember, I said we don't have to worry about the enzyme. Here's the enzymes you have to worry about. Progesterone is grabbed by 21-hydroxylase and converted into 11-deoxycorticosterone, and it's put back into the mitochondria. Biochemistry take-home question. on the pathway to aldosterone, notice that cholesterol, or the precursors to aldosterone, they're in the cytosol, then they go into the mitochondria, then they go out of the mitochondria, then they go back into the mitochondria, and then it finally comes out of the mitochondria and out of the cell. So that's a crazy pathway. You should definitely know that type of thing, and you should know these enzymes. So there's 21-hydroxylase. Deoxycorticosterone is converted into aldosterone by aldosterone synthase, and the aldosterone is exported out of the cell. Pretty easy, right? Should be review, right? Somebody tell me if that is review. I always say that, no one ever tells me anything. I assume you're getting that. So here's the key enzymes again. We already talked about them. There's cholesterol desmolase. That's that first step. Takes, well, we won't go through that again. Then we have 21-hydroxylase and aldosterone synthase, and we already talked about what all that stuff does. Aldosterone, glomerulosa cells spit out aldosterone for the third time, so we know that. I could probably get rid of this. A little review slide, I guess. The aldosterone is converted or stimulated by increased potassium ion around in the blood. The blood does not like increased potassium. Increased angiotensin II also does that. And ACTH has a very small effect to release aldosterone as well. And again, this is a review slide. It's mainly the release of aldosterone is mainly accomplished through increased potassium ion. That's the strongest stimulator, or angiotensin II is second most strong stimulator. Okay, what else we got here? It's only made in the zona glomerulosa. It's not made anywhere else normally in the body. We'll look at some conditions of hyperaldosteronism, which you could have a tumor in your pancreas making aldosterone. We'll get to that. Some fun facts from Guyton. So exerts 90% of all mineralocorticoid activity. What does that even mean, mineralocorticoid? Well, who's the mineralocorticoid? That's aldosterone. What does aldosterone do? It increases your blood pressure. How does it do that? Well, by soaking up salt and water. It reabsorbs salt and water follows. So that's what mineralocorticoid activity is. That means raising your blood pressure up. Now, this is going to get confusing. Cortisol, which is a major glucocorticoid, it actually has some significant mineralocorticoid activity, so it can raise your blood pressure as well. It binds to MR receptors, or the MR receptors of the mineralocorticoid. The GR receptors are the glucocorticoid receptors. But cortisol surprisingly can bind quite nicely to aldosterone's receptors. What? What's the deal with that? Yeah, it can. So that lock and key model is kind of bogus, isn't it? Because here is an example where cortisol and aldosterone can bind to the same receptor. So the activity, the mineralocorticoid activity of aldosterone is way more powerful. However, the plasma concentrations of cortisol is 2,000 times that of aldosterone. So there's definitely some overlap between these two hormones. Cortisol can bind to aldosterone's mineralocorticoid receptors with fairly high affinity, except here's the thing that, because I know some of you think, oh, wait a minute, what's the deal in the kidney? Isn't it aldosterone that causes salt and water reabsorption? Now you're telling me cortisol can cause salt and water reabsorption? No. It could if you have a mutation in 11-beta HSD2 gene, but most people don't. So let's talk about that. So in the kidney, there's a gene turned on in all those cells that creates an enzyme called 11-beta hydroxysteroid dehydrogenase type 2. Whew, that's a big one. Let's just call it 11B HSD2. So that will grab any cortisol that wanders into the kidney tissue and convert it into cortisone. And cortisone has terrible ability to bind to aldosterone's receptors. It just can't do it. So therefore, in the kidney, the only thing that really is working is aldosterone. right? Again, there are two key enzymes that are functioning for aldosterone expression normally. This is like the third time. I could probably take this out, but desmolase, 21-hydroxylase, aldosterone synthase. I don't know why I said that again. I could probably take slide 40 out of there. And we already went through this, so I could take both of these slides out of there. More fun facts. Aldosterone is by far seems like I already said this as well. It's by far the major mineral corticoid. I remember cortisol is a glucocorticoid. Aldosterone is a mineral corticoid, makes up 90% of all the mineral corticoid secretion. It is the body's most powerful sodium-retaining hormone. It causes filtrate reabsorption of sodium in water. It spits out potassium hydrogen. This is just a review slide. We know all this already. Hypoaldosteronism causes hypertension because if you get increased salt in water, that's going to increase the blood volume. That's going to increase the blood pressure. We already said this too, reviewing, I guess. It's a slow poke. Aldosterone is very slow. Why is it so slow to stimulate increased blood pressure? Because it's actually made from scratch. It's not stored anywhere in the body. You have to flat out make it through that long pathway that we just talked about. And it can take days before you can restore your blood volume from a rupture or an aneurysm in your liver or wherever the aneurysm occurs, or a bleed of the spleen. Sympathetic tiger is way, way faster. There are some aldosterone inhibitors. I'm not going to go crazy into this, but dopamine, strangely enough, is an aldosterone inhibitor. The adrenergic peptide or factor ANF or AMP also inhibit it. That one's intuitive. Heparin and somatostatin. I'm not going to explain. We'll just kind of leave it at that. Alkalosis and hypokalemia. So one of the side effects of too much aldosterone is it can screw up the acid-base balance, because aldosterone kicks hydrogen ion out of the serum and into the urine or into the filtrate. So if you kick too much hydrogen ion out, your blood becomes too basic and you develop alkalosis, right? Also with regard to potassium balance, if you have too much aldosterone, you kick too much potassium out, that's not good either, because that can cause hypokalemia. And that's got a whole bunch of clinical sequelae, which we'll look at when the time comes. Aldosterone, we already said, review slide, it binds to mineralocorticoid receptors. Namely, there's a MR1 and an MR2 receptor that it binds to. These are not ubiquitous like glucocorticoid receptors are. They're found mainly in the kidney, so that's good. And they're also found in the distal colon and in the hippocampus as well. There might be some research showing them in the intestines as well. So you could kind of think as the intestines and definitely the colon, you can think of it as kind of a large nephron in a way, because it really has the same effect. The colon can reabsorb salt and water and spit out hydrogen ion and potassium just like the nephron can do. There are some lower density regions of MR receptors in the proximal GI tract, the cardiovascular tissue, which is where our problem comes in, and in some non-epithelial tissues, which we won't get into. What does too much aldosterone do? That's the star of the next lecture. But that's hyperaldosteronism. And if you have too much aldosterone, you're going to have hypertension, right? You're going to reabsorb too much salt in water, and you're going to get you can get severe hypertension from that actually, and you can get hypernatremia as well. What else does it do? Well, it suppresses levels of renin, turns off. If you get hypertension, it'll shut off the R2A system, so low levels of renin. Hypokalemia, because you kicked all the potassium out, we said already. Metabolic acid or alkalosis, because you kicked all the hydrogen ion out. So we already know this stuff. So a lot of reviewing these. I could probably trim this way down. Too little aldosterone is hypoaldosteronism. And therefore, if you don't have enough aldosterone around, you can't absorb salt in water. You're going to have hypotension. Specifically, orthostatic hypotension really shows up when you stand up fast. Everybody gets a tiny bit dizzy, or most people do, and it comes back within seconds. But you stand up and with hypoaldosteronism, and you're dizzy for hours, maybe half the day. You also have polyuria, because all that water that you would normally soak out of the nephron, you can't do it anymore, so you're peeing all the time. Hyponatremia, hyperkalemia, which is all sorts of heart arrhythmias, and you get acidosis. Okay, and then the intestines fail. Remember I said the intestines are just like a nephron. They fail to reabsorb water, so if you don't reabsorb water, you get diarrhea. All right, whew, that was a should have been pretty much review for you, I'm thinking. But yeah, we'll talk to you tomorrow.